So I have nothing to disclose. Periprosthetic fractures after total knee arthroplasty is a very challenging cases because we have a very poor bone quality like this case with extensive comminution or even unstable prosthesis. We have a several challenges. The main challenges are the age, the patient factors like age, comorbidities, and medications, the bone stock as regards the existence of comminution or osteoporosis, or the prosthesis factors as regards the design of the implant, the stability of the implant, and the coexistence of infection. So by the end of this presentation, we should define the periprosthetic fracture after total knee arthroplasty and identify its risk factors, and to understand the diagnosis and different treatment options, and we will identify the outcome after treatment. What is the definition of a periprosthetic fracture? It simply is the fracture which lies 15 centimeters from the joint line or 5 centimeters from the stem of the prosthesis, or we have a patellar fracture either the surface or not. But by time we have cases like this, we have a fracture which divides the bone between two prostheses, in the hip and the knee. So it's called an interprosthetic or intercalary fracture, which divides the bone between two stable prostheses. The incidence of risk of periprosthetic fracture are increasing and became double in the last 10 years, and by expected by 2030 to increase by 6-fold. As you see in this table, the femur is more common than the tibia and more common than the patella. The revision cases is double the incidence of primary cases. The risk factors in the patient are obviously old age, the females, and the cases with rheumatoid arthritis. You have three different risk factors: our patient risk factors, our implant risk factors, or technical related risk factors, or sometimes you have a combined risk factors from two or more of these factors already. As regard technical related risk factors, the revision procedure is always a risk factor for periprosthetic fracture. As regards the femur, the anterior femoral notching, as we all know, is a major risk factor for a periprosthetic femoral fracture. As regards the tibia, the malalignment and the component malposition is an important risk factors also, and the use of a keel tibial component or a long stem tibial component. In the patella, the excessive lateral release or fat bag excision or a metal bagged patella, which is not commonly used nowadays. The diagnosis of a periprosthetic fracture depends primarily by anticipation, because most of the cases, like more than 80%, have a very simple trauma. Sometimes the patient cannot remember that he has exposed to trauma or not. The major symptoms are pain and instability. We have to ask about a pre-fracture pain, as if it is present, it may suggest the presence of instability or infection, which will change our decision completely. And we have sometimes the intraoperative diagnosis of periprosthetic fracture during primary instrumentation or a revision on instrumentation. The preoperative planning, we have to remember the 4 P's: our patient optimization for the comorbidities and exclude infection, and how to deal with the co-medication or the cognition states, pain control, proper radiograph, and always we have a plan B, because the coexistence of infection or loosening, or sometimes we need a bone graft. The X-ray, we have to scan the whole bone, because sometimes you have a periprosthetic fracture like this, and you find a hip prosthesis or hip implant in the hip like this, in this case. The fracture personality is very important. The bone quality, we have to comment about it, and stability, prosthesis of and its design. The CT is preferred to be done in every case, because we could detect an occult fracture, the existence of osteolysis, the bone loss, and you can have a better comment about the rotation of the prosthesis. So we have three main options for treatment: non-operative treatment, osteosynthesis, or revision arthroplasty. The non-operative treatment is not used very widely nowadays, but it could be indicated in non-displaced fracture in stable prosthesis or cases with severe comorbidities, or stable patellar fractures with intact extensor mechanism. It could use skeletal traction, splint, or cast, but remember that we have a high risk of non-union, malunion, and secondary surgical procedures. The revision arthroplasty obviously could be used when we have an instability or have a loosening, like in this case, or we have a pathological fracture, or a coexistent ligamentous instability, or we have a lot of comorbidities which don't have too much chances for anesthesia. But remember that we have a periprosthetic fracture and we use revision arthroplasty, we will sacrifice the whole fracture segment. So it is not an easy task. Usually, the revision arthroplasty options needs constrained or semi-constrained prosthesis. We may use a mega prosthesis like this, or we need a composite by use of allografts or metal augments. The osteosynthesis is the main treatment option we have to think in every case, especially when you have a stable prosthesis or adequate bone stock and the guaranteed purchasing of screws. The treatment options or options for fixation are the plates, the intramedullary nails. Sometimes we need an adjuvant like this case with a fibular graft or something, or the use of external fixator. The plates are the working horses for treatment of a periprosthetic fracture. As we use it as a bridging plate, we have to remember the principles, restore the anatomical axis, relative stability, and bridging for the diaphyseal comminution and minimally invasive soft tissue handling. Have some modification to coapt with presence of the prosthesis or more inside, like the use of variable angle LCPs, which have freedom by motion by 30 degrees, or the use of a locking attachment plates, which can attach the plate for more secure plate fixation in different points rather than the presence of a prosthesis, and we can use a monocortical screws like this. So we have some technical tips about how to fix the periprosthetic fracture. Number one, the position. Don't forget to do a polyester or something to flex the knee to avoid extension malalignment. Sometimes we need a double plates like this, either in the femur or in the tibia. The plate length should be adequate, at least 3 times the fracture segment in a comminuted fracture, or 8 times the fracture segment in a simple fracture. We have to use 10 to 12 screws in each side to add to have a good positioning and stable fixation. The screws could be bicortical. In every case, we have to have bicortical screws, but if you cannot use it because it has more rotationally stable, we can use monocortical. Take care of stress risers like this case, have a very simple periprosthetic fracture and well fixed by very nice plates, but we have a segment here. So it will not be surprised when it comes to you broken like this and you span the whole femur with a very long plate. In this case, we have a fracture, the periprosthetic fracture in the femur in a 95 years old woman. We have a fixation by long plates, adequate number of screws, adjuvant by fibular graft, and you have a very good, nice union, and the patient is back to his life independently. The intramedullary nails could be used also when you have a femoral fracture with an open box without stem. It's a very nice option as it's minimally invasive and the low churning implant we can allow very early range of motion, but we have some limitations like the design sometimes is not boxed already, or you have a mismatch between the radius of curvature of the bone, we have an anterior femoral bowing, or even the entry. This entry is about 10 to 12 millimeters according to the manufacturers, so you can't use the larger nails. Malreduction, especially in extension, is unfortunately is a common in use of such implants. The external fixator could be used like a temporary or a permanent, but if it's not likely to use it as a permanent treatment method, as a pin tract infection with the existence of an arthroplasty is a major concern. So usually we use it as a temporary procedure until improvement of soft tissue condition. So after that, we do a plate as a definitive. As regards the periprosthetic patellar fracture, the goal of these cases is to restore the extensor mechanism. So if it's intact, we know we use non-operative treatment. But if you use an open reduction internal fixation, we have a very high non-union rate, especially with tension band wire. Revision arthroplasty is indicated in a loose component, but you should have at least 10 millimeters of a bone stock in the patella. If you don't have, if I have an efficient bone stock, we can use a resection arthroplasty with an extensor mechanism reconstruction or allograft reconstruction for the whole extensor mechanism. but unfortunately, such cases have a higher complication rate. What about the outcome? If the union rate is about 90%, the locking plate has a better results than the traditional plates, but if we compare plates and nails, we have no significant difference in union time and union rate or operation time and even complication. What about the revision arthroplasty? Revision arthroplasty is associated with a more patient satisfactory outcome. The 4-year survivorship of the implant is about 87% of cases. Last is this nice systematic review, which is presented has been published in Journal of Orthopedic Trauma. It have more than 700 cases. The non-operative treatment is associated with a high malunion, non-union, and secondary surgical procedure rate. Conventional plates associated also with a high incidence of malunion and secondary surgical procedures. While the rim nail, the main complication was malunion, and locked plate, the main complication, which is relatively was the non-union. So the take-off messages is the incidence of periprosthetic patellar fracture is increasing with high risk factors. This risk factor should be identified and avoided. Proper preoperative optimization is crucial for all patients. Revision arthroplasty should be used in a loose component. The outcome of fixation by intramedullary nail and plate is comparable. The periprosthetic patellar fracture is associated with a poor outcome. Thank you very much.